So welcome everyone. My name is Jamie Maloney, and on behalf of Lung Foundation Australia, I would like to welcome you to our Pulmonary Fibrosis webinar, which is presented in collaboration with the Centre of Research Excellence in Pulmonary Fibrosis. So we're very pleased to have Susanne Webster joining us today to present on oxygen therapy, who I will present in more detail very shortly. So this webinar is the first webinar in the series of 3 and is also held to mark Pulmonary Fibrosis Awareness Month throughout September. So firstly, I would like to acknowledge the traditional custodians on the land on which we live and work, and pay my respects to elders past, present and emerging. So we do aim for these webinar sessions to be as interactive as possible for people who are joining us live today. So please do send your questions through using the Q&A box. You can type in any questions into this box, and this can be found at the bottom left-hand corner of your screen. And these questions will be presented to Susanne towards the end of the webinar. So I would now like to introduce today's presenter, Susanne Webster. Susanne is a clinical nurse consultant at the Royal Prince Alfred Hospital in Sydney and joins us today to share her insights and knowledge on oxygen therapy for people living with pulmonary fibrosis. So thank you for being with us today, Susanne. I will now hand over to you.
Thank you, Jamie. And it's great to see so many people joining us today. Just before we start, I'd like to thank the Lung Foundation and the CRE for the invitation to come and speak with you. It's a pretty broad subject that I've been tasked to talk about, and I hope that at the end of it, you'll see that I've just chosen the most common things that our patients ask us about here at our large clinic here at RPA, and this comes out of our experience of prescribing and helping patients with oxygen for such a long time. But I hope you'll understand that there will be some things that I do miss out on. And hopefully if there is more interest, we can maybe pick up part 2 of this at some point in the future. I know that on the call today, we've got both patients and healthcare professionals. Just a reminder to the healthcare professionals that this will be targeted just to patients. But I really hope that this will inspire you to think about some of the things that patients are interested in talking about when it comes to oxygen therapy, and help you start that conversation with them. So let's get going. So this is a bit of a plan in how today will go. So I'm keen to give you an introduction about what role oxygen plays in the body, and a bit more of a technical side as to why we're interested in oxygen. And I'm also interested in giving you lots of practical advice about supplemental oxygen. So I see today's talk as being split into 2 sections. One on why is oxygen so important for us? And the other part is how. So if you need supplemental oxygen, if you need some oxygen therapy, how do you go about it? So it goes without saying, and most of you would know, that oxygen is essential for the function of all cells in the human body. Our body won't function without oxygen. There's a few other things that it won't function without, but oxygen's a really important one. And so breathing, so the breathing cycle of inspiration and expiration, it allows us to give oxygen to the cells as they need them, and take that carbon dioxide away. So that part of it's, the technicality of that is not so important, other than to know that normal breathing, so the breathing that happens throughout the 24-hour cycle, it's involuntary. And so I think it's really important, and my patients like being reminded of this, because so often patients who are breathless experience a situation where people around them will say to them, just slow your breathing down, just stop what you're doing, just slow down, think about how to slow your breathing down. And I guess I'm here just to let you know, or just to reassure you, that that's not really in your control, and I'll show you in a moment why. It's important that you know that it's your body that decides how fast you breathe, how deep you breathe, and in what rhythm. And that's not to say that you can't control your breathing, but normal breathing, the breathing that goes on a day-to-day basis, it's involuntary. So I wanted just to talk you through with this idea of what your body wants, what your body is demanding of you. And so I talk about this idea of exertion or movement. So it's not exercise, it's not what we talk about in terms of exercise. It's more just those daily activities. It's as simple as getting up and down out of a chair, walking to make a cup of tea, having a shower, and it's also more complicated than more complex in the form of maybe walking around the block or walking to and from your cafe or doing the shopping, walking around a shopping centre. So when I talk about exertion or movement, it encompasses all of those areas. So when we do that, what we ask of our body is that the cells require more oxygen. And again, it's the technicality of that is not important, just to know that as soon as we start moving, your body decides that it wants more oxygen. And so what your body does, it changes your breathing. So you breathe faster, you breathe deeper to match that demand. And I think this concept is really important as we go on, because it helps you understand why when you have pulmonary fibrosis, this process can be interrupted. So just to go through that again, you exert your body in whatever way, even minimal or maximal, and your cells need more oxygen, and in order to provide that oxygen, you breathe more to get more oxygen in. Another way of putting this is with true exertion that we actually recognise. Our patients with pulmonary fibrosis, a very common phrase that patients with pulmonary fibrosis will use is that I could walk endlessly on the flat. I could walk continuously on the flat and have no problems with my breathing. But the second that incline changes, the second as I'm starting to walk up a hill, I really feel it. And it's the same concept that we just talked about. As soon as you require more of your body, so as soon as you start using more of your muscles, your cells ask for more oxygen, and you're required to breathe faster to keep up with that supply. So I want you just to remember these ideas as we go along as to why it might be tricky when you've got pulmonary fibrosis to keep up. So what happens when our oxygen levels fall? So I've just told you that as soon as the cells start to ask for more oxygen, our breathing rate and our breathing depth changes to keep up with that oxygen demand. Our organs send messages around the body to tell the body that the oxygen levels are too low. And some of the major organs are the most sensitive to low oxygen levels. And the brain is particularly sensitive, and it's one of the first things to respond. And what it does is it can make you quite irritable. It makes it difficult to make decisions or to do more than one thing at the time. So it begs the question, why does this affect pulmonary fibrosis patients? Why do pulmonary fibrosis patients have low oxygen levels? And it's important to look here in the second point that I'm referring to some patients with pulmonary fibrosis. This doesn't affect all patients with pulmonary fibrosis. It might not affect them at the time. It may affect them in the future. But I think it's important just to understand the concepts here rather than try and apply it to your own personal circumstances. So for some patients, we've sent out this message. The body has sent out the message that it wants more oxygen. But no matter how much we change our breathing, it's not enough. We can't get that oxygen level back up. And this happens because of the scarring in the lungs. So we use the terms scarring and fibrosis, and pulmonary fibrosis or interstitial lung disease, or the specific disease within interstitial lung disease that you might have. But for the purposes of today, let's talk about pulmonary fibrosis as being a scar within the lung. Let me show you what that looks like. So within the lung, you've got normal air sacs. And I hope that you can see my cursor here, but it's showing through here. It goes through your mouth and through the breathing tube. So this is your main breathing tube into your body, splits off to go to the left and the right lung. And as you can see, it goes through all this tract all the way to the very end. And at the very end sits these buds. Your doctors might have described this to you before, but they're air sacs that sit at the bottom. The technical term is an alveoli, but let's just call them an air sac because effectively that's all it is. It just is a way of getting the air through and the carbon dioxide back out. Okay, so this is what it looks like in the part of your lung that's not affected by pulmonary fibrosis. So for all patients with pulmonary fibrosis, there's an area of the lung that's scarred and there's an area of the lung that's normal. So where it says normal air sacs, it doesn't mean normal, so for people who don't have pulmonary fibrosis, even patients with pulmonary fibrosis have normal air sacs and some scarred air sacs. So this is what a scarred air sac looks like. So it's thicker and it's very difficult for that air to get across into the bloodstream. these air sacs no longer do their job. They don't do anything to help get the oxygen into the bloodstream or take the carbon dioxide away. In fact, they work against the rest of the body by making it quite heavy and wet. And in fact, all the normal air sacs around it end up suffering quite a lot because of this scar. So when we talk about pulmonary fibrosis, this is what we're talking about. So in some patients with pulmonary fibrosis, as your oxygen levels fall, which we talked about earlier, when your breathing can't keep up, we need to provide those normal air sacs that you have with a bit of extra help so that you can stay active and keep moving, because what we don't want to have happen is for you to stop being able to move around and stop being able to participate in your life. So the best way that we can do that, so providing extra oxygen, is the best way that we can help. So I wanted to talk to you about what is air and what is oxygen. And this leads us on to providing supplemental oxygen therapy or just oxygen therapy. So air has 21% oxygen. So what we want to deliver when we deliver oxygen therapy is as close to 100% as we can. And what this does, it helps make up the difference. So where you've got those scarred air sacs, we want to forget about those and we want to help out the normal ones who are doing their job. So the best way we can help out is by giving them extra oxygen so that haven't got 21%, they've got 100%, and they can transfer that all around the body. Other ways that we can help, so we can provide extra oxygen, but there are other ways that we can help. And I don't want to spend too much time on this because it's probably going to be included in hopefully future talks about physiotherapy and how to stay active. But really what we can do is spend a few moments resting at maximum. When you feel like you're as breathless as you could possibly be, as soon as you stop asking so much of your body, remembering that line that we had before with exertion and then the body needing more, the best thing you can do is just to rest. You don't have to sit down in a chair. You don't have to lay down in bed. It can be as simple as resting against a door frame. It can be as simple as just resting your bottom on a stool. It can be as easy as just literally stopping and standing still at the bench while you're making a cup of tea. It gives your body a chance to catch up and reduces that demand. Another way is by staging your activities. This can also help. And what I mean by that is, instead of doing a much longer task, you divide that task into smaller bits and having rest periods in between. So if you imagine one of the things that causes most people to be breathless is showering. There's lots of things going on and why showering is tricky, but one of the best things you can do is divide it up into different activities. The gathering up of your clothes and having a rest. The getting undressed and having a rest. The showering, coming out, putting the toilet seat down, putting a robe on and just having a rest. Getting up, drying, having a rest. Getting dressed, having a rest, and all looking for moments along that way of making sure that you don't get to the top of the exertion where we can't meet the demand. And the most important thing is not to let the feeling of breathlessness stop you from being active, because that creates a cycle that we don't want to get into. So that was the why. So you remember in the beginning, why do people need oxygen? Why are we getting to this point potentially? And this is the how. So I want to talk to you about when to start. How do we know to start oxygen therapy? What equipment's needed? I want to give you a few tips and tricks coming from, my years of experience. And I want to talk to you about travelling with oxygen, because it's a question that gets asked of us quite a lot. So let's start. The question I get asked a lot is, how will I know if I need to start oxygen therapy? And so we assess for that every time you come and see the doctors. So when your doctor performs that physical examination, you're most likely going to be using one of these machines, a finger probe that sits on your finger that tells you what your oxygen saturations are. And that really isn't enough on its own. So it's important, it's an important number, but also important is to look for other signs of having low oxygen levels, and that can be blue lips, or if your hands are a bit blue. Also, if you have an increased breathing rate, trying to keep up, like we talked before, the body's demanding and we can't keep up. So if you're sitting, resting in our clinic and your breathing rate is still quite high, we're going to pick up on that. We're going to register that as part of the story. We're also going to ask you about your breathlessness. When do you feel most breathless? When do you feel most comfortable? And then we put all of that story together. And based on this, the doctor might suggest that we need to do a more invasive test, which involves popping a needle into the artery in your wrist, which is in this picture just here. And what that tells us is a very accurate number as to your oxygen level in your blood. And based on that number, we might make a recommendation that you need to start oxygen. I want to take a moment just to talk about the impact of starting oxygen therapy, because what we know is that this is not a minimal activity. This is not something that is taken lightly by our patients. Some people transition into using oxygen therapy very simply and in fact feel so much better that it encourages them to use it. But sometimes it's a bit of trial and error, a little bit of adjustment period, so time for patients to get used to it. So I wanted to talk to you about some things involved in the impact of starting oxygen therapy. So there will be lifestyle changes. There will be things that you used to be able to do without thinking about having to take your oxygen. But equally, there's also going to be times when you weren't able to do things because you were so breathless, and now you can do them because the oxygen therapy allows you to get up and move about in ways that you gradually over time were stopping doing just little things, you know, not going to a particular shopping centre because the circuit around the shopping centre was a bit longer. So you just changed just little things about your lifestyle. And in doing that, you didn't register them as a big deal at the time, but hopefully with oxygen therapy, you're not actually needing to think about those things, that it's a bit easier to get around. So yes, there will be lifestyle changes, but sometimes they're for the better. Patients also describe that up until the time they start using oxygen, they were able to keep their disease private, that they were in charge of who they told. And as soon as you go onto oxygen therapy, your story is told without your permission. That you can see my disease now, that I wanted to keep it private, but now I need oxygen therapy, everyone can see. And this is a different story for everyone, but it's at that point in having a chronic illness that it's really obvious to the patient that their need for oxygen therapy really has to trump how they're seen. And that's not a minor thing, and I don't say that lightly. It does take an adjustment period for some patients, and I think the healthcare professionals on the webinar need to really spend some time thinking about how to approach that with their patients. In terms of the justification for needing oxygen therapy, a lot of what we've already spoken about, but this need to prevent further impact on your organs, particularly your heart. We want to prevent deconditioning. We want to stop you from losing fitness, because it's fitness that keeps you being able to easily move around. And the deconditioning story is much more complex than that. And I don't want to minimise that. There should be in future talks a conversation about deconditioning. It allows you to continue to participate in all aspects of your life and do things that you might have stopped. And it's important for me to say that it's not always reflective of a decline in the disease. So often patients will see it as what has happened because their disease is declining or has declined. So it's absolutely the case that when the scarring affects more air sacs and makes them scarred rather than normal, we obviously need to use oxygen therapy to keep up with that. But it doesn't always mean that it's a continuous process. It might be that you've had a decline, you now need oxygen, but we've otherwise stabilised you. It also might mean that you have declined and you are gradually over time declining and benefit from oxygen. I want to cover a few myths just quickly, and this idea that we can become addicted to oxygen and that we need to save the oxygen for when you really need it. And it's to say that we're all addicted to oxygen. I'm addicted to oxygen. Jamie's addicted. We're all addicted to oxygen. And this idea of saving it up for when you really need it, well, you really need it all the time. And we'll go into that with oxygen prescription, because some patients don't need it 24 hours a day. Some patients are okay with 18 hours a day. Some patients are just at night time, but we'll talk about that in a minute. But whatever your prescription is, it's a decision that's not taken lightly by your doctor. So whatever they've recommended, it's important that you think about ways that you can go along with what their prescription is. Just like if they prescribed you heart medication, you would take the heart medication as prescribed. There's also a myth surrounding that you can train your body not to need it, so that you can just use it when you really, really need it, and so you save it up for when you don't, and that it's okay to only use it when it's convenient. So not when you go out, not when you are out and about, that you can just use it at home. And that's absolutely not true. You should be using it as often as your doctor has prescribed it. And you need to chat with the people who are looking after you about how to incorporate this into your life if you're struggling to work out how to do the things that you like to do. And that's what we're here for. We're here to help you discuss how to stay active and how to stay connected. Okay, what do you need to have oxygen? When you're prescribed oxygen, what equipment do you need? Well, you need an oxygen source, and I'll go into all of these things. So you need either a home concentrator or a portable concentrator, or you will need a cylinder of oxygen. So that's the oxygen source. You'll also need something to deliver the oxygen. So that's either the nasal prong shown here on the right-hand side, or the oxygen mask on the left. And you'll also need some oxygen tubing. I'll cover as to why. But this is the equipment you need, and the oxygen provider will help you set all of this up, so you don't need to remember all of this. So I want to tell you what an oxygen concentrator is. So we learned earlier in the talk that air has 21% oxygen. And so what a concentrator does is that it feeds air in via a vent here on the back, and it goes over a bed, a sieve bed, and that sieves out just the oxygen. We want to just deliver you back oxygen. So it takes away the nitrogen and the other inert gases, and it feeds you back just oxygen. And so that's where the word concentrate comes from. So it takes air and it makes it concentrated by choosing just to keep the oxygen molecules. So what's the difference between a home concentrator and a portable concentrator? So you can see here in the picture, the scale is probably not very clear, but you can see here in the picture that we've got this larger machine here. It weighs, how much does it weigh? I think it weighs about 10 kilos, but it's on casters, it's on wheels, and you can wheel this around your home. It's not portable. You can't pick it up and take it out for the day. It runs on electricity, so you plug it into the wall and that's how it powers the motor. And it gives you, via this dial here on the front, it gives you 1 to 5 litres. So 1 litre, 2 litre, 3 litre, 4 litre, 5 litres per minute oxygen. And if you get a much bigger machine, a similar version to this, it can go up to 10 litres. On the other hand, a portable concentrator, it's the same idea. Draws in air, concentrates the oxygen, and feeds it back to you as oxygen rather than air. They're smaller, they are portable. They call them transportable rather than portable. It's on wheels. You can see here I've kind of cropped it too much, and this is like a trolley like you would have with a suitcase. And it runs on a battery. So the battery sits here, in this case on this machine on the bottom here, and it can give you up to 2 litres per minute. It doesn't go up as high as the home concentrator, because they can't miniaturise, they can't make the motors small enough to survive on that size of a battery. So that's the difference between a home concentrator and a portable concentrator. In addition to the other oxygen source that you can have outside of hospital is an oxygen cylinder. And you've probably all seen one of these. This is called a C-size cylinder. These are the right size for patients, because once they're filled up with compressed oxygen, they weigh about 4 kilos, and full, I think they weigh about 6.6. And what happens is you use the contents and you get it refilled or replaced. So you either you swap it over at a service centre, so somewhere that deals with oxygen, so an oxygen supplier. They either refill your existing cylinder, or they just give you a fresh one. And on the top here is what we call a regulator. And so what it does is it takes this cylinder here and allows the gas to come out. And it's got a dial here to tell you how much it's dialing up to. You can dial up to as much oxygen as you like on here, up to 12 litres on those standard regulators. And the contents of the cylinder last depending on how much you use. So this is, we're looking here at the C-size cylinder. So that's the cylinder that I showed you just a moment ago. And you'll see here over on the left that depending on how many litres, so 2 litres, 3 litres, 4 litres, and this is how long they last. So this is the column we're looking at. So at 2 litres per minute, this cylinder will last for 4 hours, 3 litres for 2 hours 43, and 4 litres for 2 hours. So that just gives you an idea. The numbers aren't important. It just gives you an idea that the cylinders are good for delivering continuous flow and meeting your home prescription. So if your home prescription is 2 litres per minute, you need 2 litres per minute when you go out as well. Which brings us to the oxygen prescription. So your doctor will decide firstly how often you need to use the oxygen and also how much oxygen you need. So you'll either, an example of an oxygen prescription is 24 hours a day, so that's how often, and at 2 litres per minute. And that could be 24 hours a day at 4 litres per minute, or nighttime only at 2 litres per minute, or just 18 hours a day at 2 litres per minute. The most common prescription for patients with pulmonary fibrosis are these top two. So 24 hours at 2 or 4 litres per minute. They're the most common. They're the ones that we see the most. Obviously, if we've got that home concentrator and we've got the prescription for the home concentrator, for instance, say it's 2 litres per minute, we want to be able to leave the house. And we know we can't move that big machine with us because it's plugged into the wall. And the question that we get asked most often is, how do I decide which portable oxygen to use? And I'm here to unfortunately tell you that there's no right answer. There are advantages and disadvantages to both options, and it really depends on the patient's lifestyle. And the best decision will depend on how you can fit either of these two options into your life. So let me show you a bit more about that. So this is quite a busy slide, but you should have access to this later on after the webinar to be able to go back through. But just to run through it fairly quickly, a portable oxygen concentrator is expensive to buy. They're around $5,000 to buy. You can rent them for around $8 a day. You don't refill them in the same way that you refill portable cylinders. The way you refill them is by charging the battery so that concentrator part of the machine can work. A battery in the machine that you need continuous flow, because you've got continuous flow at home, you need continuous flow when you go out. The battery lasts less than 1 hour. And so I'll talk in a moment how to get around that, some of the lifestyle tips and tricks to get around that battery lasting less than an hour. As I said, it weighs about 6 kilos and it's on a trolley. And for patients with a prescription of 2 litres per minute, you are limited to the types of machines that you can use. And I'll show you in a moment what I mean by that. With portable cylinders, the cost of the cylinder is the rental of the actual cylinder itself. So you rent that from an oxygen company and then you pay per cylinder refill. And that cost varies from state to state. So I don't want to give you an actual price. But it's normally less than $20 to refill. You refill, as I said earlier, by taking it to a refill centre or paying for delivery, and it lasts up to 4 hours. When I look at, 2 hours, 3 hours, 2 litres, 3 litres, 4 litres per minute, it lasts up to 4 hours, as we saw on that grid just a moment ago. You can have them in a backpack, on a trolley, or you can even put them on a 4-wheel walker. So for patients with portable concentrators, there are a lot of concentrators on the market. And the most attractive machines for patients are the small machines that you can obviously, that are easy to carry around. But unfortunately, the smallest machines on the market that some of you might know about are machines that look like this, which is called an Inogen. This one's an Inogen G3. So these are the small machines. They only do pulsed flow, they don't do continuous flow. And the maximum that this machine can provide in this particular machine, the maximum flow is 1 litre, just over 1 litre per minute. So if your prescription is 2 litres or more at home, then this machine won't work for you, unfortunately. It is incredibly attractive because it is quite small. You don't need the trolley for it, but unfortunately it doesn't match your home prescription. In terms of the home concentrator, the setup of the home concentrator at home is it's much more practical to find a good spot for it. It can be loud, the engines can be loud, the motors can be loud, and depending on the layout of your house, it's best just to pick a spot and then use the oxygen tubing that I showed you the picture of before to create a bit of a circuit around the house. When you design the circuit, again, think about the noise from the motor. So you probably don't want it in a bedroom, but a hallway might be okay with a closed door. We want you to make sure that there are no rugs or anything hazardous in the way that you might pull over a hall table or you might trip on a rug. And we want you to be at all times thinking about how to hold that oxygen tubing up and away from your body so that you can walk freely. So holding it away from your body when you've got this big long circuit that goes all the way around your house, as long as you're holding it away from you, you can walk ahead. So I promised you some tips and tricks. So I'm not sure how well you can see this. Hopefully it's coming through okay, Jamie. Is it big enough? Yeah. So what patients worry about most with the portable concentrator is having enough battery. I've told you that it only lasts an hour. We'll say you want to go out for longer than an hour. What can you do? So the way you can do this, what I call seamless charging. So you're at home, you're on your home concentrator, and you leave your home concentrator and you use your portable concentrator to walk to the car. You don't walk without oxygen. You walk with your portable concentrator to the car. And then you can use, I've shown you here, a car charger. So you use the battery plugged into the car charger, and then you arrive at your destination and you get out, you're going for a coffee with some friends, and so you take your concentrator out, you unplug it from the car charger, and you take your mains charger, so the charger that you use to plug into the wall, you take that into a cafe and you sit at a table near a power point and you plug in. So your battery is still charging. So you finish there and you want to go to the shops on the way home. Well, there's no battery charger in the shop, so you can't just be connected to charging. So what you do is you use that battery. You've got an hour. You make it back to the car, use the car charger, get home, use it to get up to your home concentrator and go back onto your home concentrator. So it does require a few extra steps, but you can have this, what I call seamless charging, where you can just go from step to step to step. Some patients on oxygen therapy complained about nostril dryness and bleeding, and you can use non-petroleum based lubricants. So don't use things that are based on petroleum like Vaseline. So use medical grade sesame oil, which I've shown you a few brands here, one in a spray, one in a drop of what's called NOS oil, that can lubricate the inside of the nose. And what you can also do is discuss with your doctor whether you can have very short periods off oxygen. So if you're on a 24-hour prescription, you could have a conversation with your doctor. If I was sitting at rest and not doing absolutely anything, not bending over, not picking anything up, not talking excessively, could I have 15 or 20 minutes off? But that's a conversation that you need to have with your doctor. You can also have a conversation with your doctor as to whether it would be appropriate to use a humidifier. You should, as an additional tip, you should always use your oxygen in the shower if you've got a 24-hour prescription. Patients tend to like to have the shower off, but it's actually the time when you need it the most. It's the time that our patients complain about being most breathless. And even if you're on an 18-hour prescription, the shower is really the time when you really want to be using your oxygen. Now, I wanted to spend the last part of the talk just talking briefly about travelling with oxygen. And it's to say that just because you're on oxygen doesn't mean that you can't travel. And often interstitial lung disease affects patients at a time in their life when they're thinking about retiring and using some of their retirement life to travel. And so I just want to reassure you that in consultation with your doctor, you can make plans to travel. It's important, particularly in this point, to make sure that you understand that, as with all the information I've talked about today, it's general advice only. You can't use this to apply to your own case, but you can use this information to start a conversation with your healthcare team. When it comes to travelling, it's no more important. There's never a more important time than before you do anything, before you make any bookings, before you make any plans, just have a conversation with your healthcare team. So let's talk first about travelling by car. So grey nomading, or just travelling interstate or travelling locally. If you're using oxygen cylinders, these need to be secured in the backseat footwell, ensuring that they're secure. If you imagine that you're in an accident, that is a big missile that could be going around the car. So we want them nice and secure in the back seat, in the footwell. You should be able to see the regulator at all times so that you know when to change over your cylinder. When it runs out, you need to know when it's running out. You need to have enough oxygen in the car to account for unforeseen delays, so roadworks that you didn't anticipate. So make sure that you over-order. And you can actually plot a trip, interstate or throughout the state or territory, based on where you can swap over your cylinders for new. And obviously we talked about plugging in your portable concentrator, and you just use the car charging kit and you use it based on your need in the car. And obviously it should go without saying that at no point in time should anyone with an interstitial lung disease be around someone who's smoking, but particularly patients who are using oxygen therapy should not be near any naked flames. And that includes cigarette smoking. Lots of patients that we see would like to travel on cruises, and so again it's a caveat that you need to discuss this with your doctor. You'll need a portable oxygen concentrator for this trip because you can't take on enough cylinders to last you. It needs to be suitable for your prescription. So whatever machine you decide to use, it needs to be suitable to be used 24 hours a day, and that conversation can be had with the oxygen supplier. You need to ensure that the cruise line's aware of your need for uninterrupted power supply, so you need to register that with the cruise line that you'll be taking on a oxygen concentrator, and ensure that they've got oxygen supplies in the event of your equipment malfunctioning. You may need a medical clearance form signed by your doctor as well for cruising. Travelling by plane can be a bit trickier, but I don't discourage you from doing it. You will, if you're currently using a 24-hour prescription, you will absolutely need to use oxygen on the plane, so the next slide will apply to you regardless. However, there's a group of patients who at sea level, so ground, not in the air, don't require oxygen. And your oxygen levels, and when we assess you, you're perfectly okay. But we have a suspicion that at altitude you might drop your oxygen levels. So we recommend that you have a fitness to fly test where we simulate, we pretend like it is that you're at high altitude, and we see how your body behaves. And for some patients who are completely fine on the ground, you actually need oxygen in the air. So how do you go about that? Your options are one of two things. So you can either take your own portable concentrator or rent one for the trip. It has to be particularly approved by the airline. Almost all of the ones sold in Australia are FAA approved, but airlines don't let you use their own power supply on board. So you have to take enough batteries to last 1.5 times the flight time. So say you're travelling from here to Singapore, you have to take, it's an 8-hour flight, you have to take 12 hours of battery life. So you have to take enough batteries to last the whole trip. You need also to ensure that those batteries are stored in the right way, and if you go down that track, the airline will instruct you about that. The second option, so that's the first option, to take your own concentrator. The second option is that the airline can provide oxygen in cylinders on board. And depending on which carrier you use, some of them provide them free of charge, and Cathay Pacific is one airline that we've recently had some contact with and they've not been charging our patients. And other airlines will charge you a nominal fee plus a per cylinder use. Some airlines will ask you to pay for a second seat to accommodate that cylinder. So my recommendation here, as you can see, is to shop around before you book. Don't rush into these decisions to go ahead and book. For international and some domestic travel, you require a medical clearance form, so make sure you get that in good time. Don't travel with low-cost airlines. They're very unfriendly to patients who need oxygen. And if you are on a code-shared airline, if you've got a ticket that's code-shared, then you may have problems. And what I mean by code-shared is that you buy a Qantas ticket, but your actual aeroplane that's servicing that flight is actually an Emirates flight. You have huge amounts of problems in that case. So if it's a Qantas flight, just make sure it's a Qantas plane that's flying that, so that all the forms apply to that particular carrier and it's not different to your ticket. I've also got some general travel advice, and that is that if you cannot afford insurance, you cannot afford to travel. You must declare your disease as a pre-existing condition, and you will pay more money for this. You will pay a higher premium to cover that, and you will need to shop around to get that premium. You may call the first 5 places and they say, we just won't cover you. Just keep calling around. You will find an insurance company that will cover you. And I can't state it strongly enough, please discuss your travel, particularly plane travel, with your doctor prior to making any of these bookings. Because even if you've flown 6 months ago, you need to make sure that the advice that the doctor's given you, if they okayed the trip 6 months ago, it doesn't mean that it's okay today. It needs to be current. So in summary, just to tie everything up, we're all addicted to oxygen, and if there comes a time in the development of your disease that you need oxygen, hopefully some of the information that we've given you today will help you start on that path. And just a refresher that sometimes in pulmonary fibrosis, and that's not the case with all patients, but for some patients, you don't have enough of the working air sacs. So the normal air sacs that should be doing the job, they're scarred, and we call that pulmonary fibrosis. So we need to give you some oxygen to help out the normal air sacs. We want you to stay active and participate in your life. So I can't impress upon you the importance of this, that oxygen, instead of being a problem for your lifestyle, can actually be a huge benefit. And in a lot of cases, patients come back to us and say, I had no idea how unwell I was feeling beforehand, and I actually feel great now that I've started on oxygen. And I think based on that, and given the time, we'll open things up for questions. So if you've got any questions, Jamie will come back on now and talk to you about how to do that.
Excellent. Thank you, Suzanne. So much information to take away from that, so thank you. We have had a couple of questions come through, and we do have some frequently asked questions from the Information and Support Centre as well. So I'll open up with one. So I know you are in New South Wales. It's just a question. So in Queensland, MAS doesn't supply cylinders for community access or the portable oxygen concentrators. So do you have any advice for those that are on the concentrators only and may not be able to afford to hire a cylinder when they need to access the community without oxygen to go shopping or catch up for coffee dates and things?
Sure. My first advice would be to discuss with your treating doctor, because all patients are different. So having this conversation with your doctor, it might be that the doctor says that it's okay for you to go out without oxygen for periods of time where you're sitting in a car to get to somewhere, but you're spending a very short amount of time transferring. So literally from a mobility access car park, less than 10 metres into a cafe, sitting and resting and coming back. But it's important that you have this discussion, a very specific discussion with your treating doctor, just so they know that it's not within your financial means to be able to afford portable oxygen, and that you do want to participate in the rest of your life and you want to know how to do that safely. So unfortunately, it's bordering on like specific advice, and I don't really want to give that, other than to say that most respiratory physicians understand how complex it is navigating affordable oxygen. And we know how expensive it can be for patients who aren't covered by government funding. And if it means that the doctor's unwilling to negotiate leaving the house without that, there are home-based programs in most states where you can do exercises in the home just to remain active. So I know that that's not the best solution, because everyone wants to be able to leave their home, but I would encourage you to have a very frank discussion, a very specific discussion. I would like to do X, Y, and Z. I would like to do this. How do you feel about me doing that? Is there anything that you can do? What I would say is, if there is a time when you don't have oxygen on and your prescription is for 24 hours a day, the least amount of effort, exertion, movement, like we talked earlier, the least that you can ask of your body, the better it is for you. So if you do go out without it, that you're sitting in a cafe and you're not bending over to pick something off the ground, you're not talking without a break, you're not lifting your arms in the air and talking with your hands like I do, like you've seen me do here, just trying to ask as little of your body as possible and to sit comfortably.
Okay, excellent. Thank you. What about CPAP machine? So can a CPAP machine and oxygen cylinder be used together?
So a CPAP machine can be used with oxygen. We call it entrained. So you can put the oxygen through the CPAP machine, and you need a special T-piece. So whoever's prescribed your CPAP machine or a sleep devices centre could give you a T-piece, and that your oxygen, not from a cylinder but from a concentrator, could go through that. And the reason you can't do it through a cylinder is that we sleep more than 2 hours and 43 minutes. So you need a cylinder that will cope with continuous flow, and that's why you put your oxygen concentrator, instead of having it sitting outside the door, you have the oxygen concentrator sitting outside the door, but the tubing coming into the CPAP machine and on the T-piece connecting there and then into the CPAP machine. So this is a conversation you need to have with whoever's prescribed you the CPAP. And if you haven't seen anyone about your CPAP for several years, make an appointment.
Thank you. Do you have, this one is quite specific, but do you have any advice for someone asking how common is it that patients don't feel any better after commencing oxygen?
Yeah, it's a great question, because it's one of the biggest obstacles that we have to encouraging patients to use oxygen. If you imagine that we're asking you to do something that we can't prove to you that you're not feeling any different with, the only way for us to prove to you the benefit is by showing you things like how your heart rate changes when you're on and off oxygen. So remember, we were talking about exertion and movement and your body asking for more oxygen. When you don't have enough oxygen, it's trying to get the same small amount around, but faster, because the body's like, come on, I really need it. So your heart pumps faster to get it around. And so what we could show you is what happens to your heart rate or your pulse when you've got oxygen on and when you don't. And that's the biggest difference. That's the easiest way we can show you. We could pop a needle into that artery and show you, but that's really invasive and painful, and we don't need to do that. But and patients describe this. Patients describe, when I've got my oxygen off and I quickly want to go to the bathroom, my heart's pounding out of my chest when I get back. And what we want to do, you've got a lung problem. We don't want a lung and a heart problem. So if we can take the pressure off your heart by making it not under pressure and not beating faster than it needs to, then we've proved our benefit there. But I totally take the point of the questioner that it is really tricky to stay on something that does affect your lifestyle so much when you don't actually feel any better. But what I would say is you might not feel any better, but your body feels better. Yeah,
Okay.
that's basically, yeah.
Yeah, thank you. Just one in regards to the prescription. How often around about should the prescription or flow setting be reviewed for someone on oxygen?
Yeah, that's a great question. I think by default, your doctor does that pretty much every time you go in. And because we know that if we remember back to the picture of the scarring, we looked at the air sacs, that doesn't change, it doesn't get better. And so if we imagine that the reason why we put you on oxygen was because your air sacs were scarred, then it's probably going to be that you will remain on oxygen because that scarring can't be undone. So every time you go and see the doctor, they're doing an assessment on you. They're putting that probe on your finger. They're looking at your fingers and your nose and your ears and your tongue to see if it's blue. They're asking you about your breathlessness. They're asking you about what you can and can't do. And so effectively, they're assessing your need for oxygen at every visit.
Okay, excellent. We do have a couple more from the frequently asked questions as well. Can people access different shaped nasal prongs if they experience discomfort? I know you covered some great tips for the discomfort with the dryness. But are there
discomfort's a really big problem for some patients, and it's particularly a problem for women who might have smaller nostrils. What you can do is request from your oxygen supplier paediatric cannula. So they're for children, but it's important that you ask what flow rate they're tested on. So some paediatric cannulas will only take oxygen up to 2 litres, and if you're using it for 3 or 4 litres, you don't want to risk that cannula breaking. So if the cannula, the nasal cannula, so the prongs that go in your nose, match your prescription, if that particular brand matches, then that's okay to use paediatric cannula. But I would recommend that you ensure that the flow rate matches. I would discourage people from cutting the cannula because typically when you cut it, it changes. So I think you can see my finger. So the probe are shaped like this. So what it's designed to do is the nostril sits here and it's designed to go through, and so the air doesn't escape back out into the atmosphere. The oxygen doesn't escape back into the atmosphere. And so when you cut down the ends of the probe, it changes the engineering of that particular probe. So I would discourage people from cutting the probes. Also, when you cut them, you're at greater risk of stabbing something inside the nose, and as you know, it's really sensitive.
Okay, great. And now we'll finish up with this question just in the interest of time. So should you have an altitude test every time before you fly, even within 6 months?
So this is a decision that's made by a doctor. So the testing for an altitude test is a decision that's made by a doctor. So it's not a test that nurses or physiotherapists or respiratory scientists order. It's only a test that's ordered by doctors. And it goes back to my really important advice. It's about having a discussion. So whether you should or shouldn't have it is a decision that's made by the doctors, because if you don't travel with oxygen, then and you've discussed it with your doctor, they're saying to you that you're fine to travel without it.
Okay, excellent, Susanne. That's really some really helpful advice there, which is excellent. Thank you. So we will wrap up the questions there. Thank you to everyone that did send their questions through, and for everyone for taking the time to join us for today's webinar. Susanne, thank you so much again for your presentation today. As mentioned, this topic in particular is something that we do get a lot of questions about in the Information and Support Centre. So it's great that you've been able to provide such valuable information, not only for today's audience, but for future reference as well. Thank you again to the Centre of Research Excellence in Pulmonary Fibrosis for their support in holding these webinars too. So before I do wrap up, I just wanted to mention the services and resources that the Lung Foundation do offer for people with PF and IPF. So most recently, the Life with Pulmonary Fibrosis resource was launched. So there are still a limited number of hard copies that are available, which you can access by calling the Information and Support Centre number, and that's the free call 1-800 number that you can see on the screen. A digital version, of course, is available on the Lung Foundation website, along with a number of IPF resources as well, including the IPF fact sheet that you can see there. So some of you may be aware of the Lung Foundation's Peer Connect service, which aims to match eligible people living with PF and IPF, as well as their carers, with someone going through a similar experience. So this is a telephone-based service and can be accessed throughout Australia. So if you would like to find out more about registering for this service or referring any patients to the service, again, please contact the Information Support Centre on that 1-800 number. And you can easily stay up to date with information regarding these services and resources, as well as education seminars, training, events and research by signing up to receive these from our website. So this can be accessed from the home page, and you'll see the Get Involved tab and sign up to our newsletter, and you can indicate which communications you would like to receive from here as well. So finally, we will email out the recordings of each of the webinars along with the evaluation survey at the end of this series next month. So please do take the time to complete the evaluation and help us to shape our future webinars. So again, thank you so much for joining us for our first PF webinar in this series, both to the participants and again to Susanne as well. You can see the details of the next 2 webinars that are on the screen, and we look forward to having you join us then. So thanks everyone.
Okay, so I've just popped back to answer a few follow-up questions that we happened to see after we closed down the webinar when we first presented it. And when we closed down the webinar, we saw quite a few really good questions. And so I spoke to the Lung Foundation, and they were very supportive in giving us some more time to answer some of those questions, because they were really fantastic questions and I really want to have the opportunity to answer them. So I'll just show you some of these questions. So one of these are the 2 questions. So the questions that were asked were surrounding the difference between pulsed flow and continuous flow on portable oxygen concentrators. And also a really nice question about the night setting on the Simply Go concentrator. I know that there were other questions, and if you have any further questions, I'm very happy to be contacted by the Lung Foundation to answer any of those that you need answering. But we'll just cover these 2 questions that came up after that the original webinar. So I want to start out a conversation about pulse and continuous flow oxygen by just reminding you that oxygen is a drug, and as such it can only be prescribed by doctors, and in some states it can only be prescribed by certain doctors, so only certain doctors have that ability. And I just wanted to show you an example of a medical prescription, and I'm not sure how well that shows up there, but the important features are that we're communicating directly with a company that is licensed in Australia to provide oxygen, and that's also controlled. So we're writing to the oxygen supplier, we're identifying you as the patient, and we're nominating exactly what it is that we want you to be supplied with. So that could be, as you know, a home concentrator, some cylinders, or in this case, in this particular example, a portable oxygen concentrator. And in addition to saying what machine or what device it is that we're wanting, we also want to tell the company the flow rate. And this will become important as I show you a few more steps along. And in this case, for this particular patient, where the doctor is asking for 2 litres per minute. So that's a reasonably common prescription for oxygen. So they're asking for the patient to be supplied 2 litres of oxygen per minute. And so this prescription goes to the oxygen supplier, and without this, the oxygen supplier is not legally allowed to supply oxygen to patients, because it's just like a drug. It's just like going to a pharmacy without a prescription. Okay, so based on this, I wanted to tell you a bit more about the oxygen concentrators. And the reason for this is that we had a question that said that a particular machine, in this case an Inogen G3, which is a pulse-only machine, was able to do 5 litres. And I just wanted to show you a bit more about that and just to clear up some misconceptions. So I'll first start with the machines that do continuous flow, and that is, in this case, this is an example of a machine that does continuous flow. And as you can see, it's called the Simply Go. That's it here, and you can see in the table here that it does continuous flow settings up to 2 litres per minute, and that's the most that these kinds of concentrators do. It also does pulse mode, so on setting 6, and it's really important here that we remember the difference between litres per minute and settings, because that will become a very important part of how we go on with this particular discussion. So for pulse mode, they talk specifically about flow settings, and you can see that in the diagram there where it says flow setting. And for this, in this particular case, if you start out at setting 1, for every breath that you take, you get 12 mils of oxygen. Don't focus on this too much, just focus on the total amount at the end. So in this case, if you're on setting 6 and you can take up to 20 consecutive breaths, the maximum that the machine can provide you on setting 6, so it's not 6 litres, it's setting 6, the maximum that it can provide you is 2 litres in a pulse mode. And it will use the same amount of battery on pulse mode as it will using the continuous flow method. So that's the 2 litres here. So if you were going to go on to 2 litres, it's just as good to use the 2 litre continuous flow in this particular device. But I want to show you where this question came about. And so it's completely understandable why there is a misunderstanding about this. So this is an example of a machine, as I said earlier, called the Inogen 1. You can see that on the screen here. Hopefully you can see my pointer. And it's the model G3, but it's similar to the G2 that you might also see on the market. And you can see here in the LCD display that it says setting 5. And so what that means is not that it's 5 litres. It means that it goes up from 1 to 5, and with each increase from 1 to 5, it gives you slightly more oxygen per breath. And what it does is totals that oxygen all up at the end to work out in 1 minute how much oxygen you would be receiving. And I can show you this from the actual manufacturer's manual, and that's shown in this diagram in this table here. So it's important just to forget about all the stuff on the right-hand side and just focus on this part of the table here. So in the setting, so as you can see here, flow setting, and that's what it looks like on the LCD. So when it says setting 5, what you're actually receiving, so that's what it says in the flow rate, is 1 litre, so 1,050 mils. So it's 1.05 litres. We can probably just call that 1 litre. So this is, as I said, from the manufacturer's manual, so it's important that you know that they're really transparent about how much their machines can deliver. And at setting 5, which is the highest setting, the highest setting, the maximum amount that this machine can deliver, as you can see here, with setting 5, it delivers just over 1 litre, okay? And that's actually mentioned here also, as you can see from the bottom, from their technical manual, that the Inogen 1 G3 delivers up to 1 litre of 90% oxygen. That's about as pure as any concentrator will get. So around 1 litre of almost pure oxygen. And it also notes here that for those users out there who might have a G2, so they refer to their earlier model, and their earlier model delivers a little bit less than 1 litre, about 800 mils per minute, so not even quite 1 litre. And so
I think it's important when I saw this question, because it is a very common misconception. It's not something that just one person has thought. This is a very common misconception that setting equals litres, and as I've shown you here, it doesn't. Now, that's not to say that you're in consultation with your doctor that this machine has been decided to be the machine that treats your low oxygen levels as being appropriate. And I don't want to recommend one way or other whether the suitability of this particular machine for you. However, what I do want to do is make sure that you realise that if you are going to use this and you are wanting close to 2 litres, that you need to be using it not on setting 2 for 2 litres, you need to be using it on setting 5, because that's the closest to 2 litres that you'll get. So just to say that again, if your prescription is for 2 litres and if your doctor has approved for you to use a pulse flow machine, then setting 5 is the closest setting that is the closest amount to a 2 litre prescription. So it's not setting 2 for 2 litres. Setting 2 is much lower. I'll go back to that. Setting 2 is only 400 mils, so not even half a litre per minute. So I think it's such a timely question, because it really does bring to the fore the importance of recognising that settings don't equal litres. And it's perfectly reasonable that you would think that it does, but it's important that you know that it doesn't. And as I said, and I can't state this more strongly, is that if in consultation with your doctor, this machine has been approved and this is what you're using to treat your low oxygen levels, then this is not designed to get in the way of that. It's just to educate you about what setting to use if this machine is the one that you're using. Similarly, there is another kind of pulse machine that you might see on the market, and this is called a Simply Go Mini, not to be confused with the Simply Go. So the Simply Go is that bigger machine and it does continuous flow. So when you see the Simply Go Mini, you'll see here in the table lots of information, but the important part of this table is over here, and hopefully again you can see my pointer, but it's in the middle of this table where it says setting 5. Again, the maximum setting for this particular pulse flow machine is the maximum amount that you'll get is 1,000 mils per minute. So that's 1 litre. So going to use these machines, and again, if they are approved by your doctor, then go ahead and use them, but don't use them on setting 2 for 2 litres, use them on setting 5 for 1 litre, okay? So just to round out this conversation, some patients do use pulse flow machines, but if it's a continuous flow that has been ordered by your doctor, then the Simply Go, the standard Simply Go, or there is another machine which can be a bit tricky to find at the moment called an Eclipse 5D. We showed that in the webinar. But if you spoke to your oxygen provider, they would know that. If you let them know that you've been prescribed continuous flow and that's what your doctor's wanting, then it's the Simply Go or the Eclipse 5D. And those machines provide continuous flow, so you don't have to worry about what setting it's on. It's just setting at 2 litres. And in this case, going away from this conversation, all I want you to remember is that settings do not equal litres, okay? And I want to also answer a question that another patient had, and it was about the night setting on the Simply Go. And it kind of relates to this conversation about continuous flow or not. And I guess just to clarify, if you're using oxygen 24 hours a day, or if you're using oxygen just at night time, really depending on what that prescription from your doctor is, and you're not using a home concentrator, remembering the home concentrator is that blue machine that sits stationary somewhere in your house, and then you create the circuit around the house with your nasal prongs. If you're not using one of those machines and your doctor has recommended instead that you use a portable oxygen concentrator, then you should only be using the night setting if in the daytime you use the pulse setting. If you use the continuous setting, then you shouldn't use the night setting on the Simply Go. You should just continue to use the continuous setting. And so I just wanted to tell you what the night setting does. So it's a bit tricky to explain, but I wanted to make sure that I did explain it so that if you wanted to look into it, you had a starting point about where to look into it. So the way the pulse machines work, for those of you who have used them, when you put the nasal prongs into your nose and you change the pressure inside your nose by inspiring, so you'll breathe in, and in that moment, it changes the pressure inside your nose. The machine's really clever and it picks up this change in pressure. And what you'll hear is the pulse flow of the oxygen, and it will feed you that oxygen delivery for that breath. And so what happens in the night setting is that because we breathe differently at night than the way we breathe in the daytime, it lowers the amount of pressure change that you need in order to trigger that breath. So it lowers the amount of change from normal pressure to inspired pressure. So when you take a breath and then at nighttime, you might not take a breath with such force. It's quite a tricky concept to explain actually, but it lowers the trigger. And so instead of needing a lot of pressure change, it just needs a smaller amount of pressure change. And I guess that's kind of enough information to go on with from there. I don't really want to go over that too much because I think it will probably just get confusing. But if you just remember that it's designed, it's in the system of the Simply Go in order just to acknowledge that for some patients, it changes according to how we breathe in the daytime. We breathe a little bit differently at nighttime. So I hope this has helped to answer some questions that we did see at the end. I'm sorry if your question was not seen or hasn't been answered, but I am very happy to answer questions related to oxygen generally. And just a reminder, I can't actually comment on specific prescriptions or give you medical advice or health advice. But I really encourage you to use this information to have a conversation with your doctor or your treating team. And if you need any more information to help you have that conversation, I'm happy to give you that information about the machines or about oxygen delivery overall, or about being on oxygen and staying on oxygen. So if you need any of that information, I'm happy for you to contact the Lung Foundation and I can help you answer those questions. Okay, thank you.